All right, well, good morning, everyone. I'm Larry Boris, Executive Director of the National Association for Workplace Healthcare. I want to thank you for joining us today. This morning's topic is leveraging a cloud native EHR to drive value in a worksite clinic. And we're going to have two organizations that will be presenting that will talk about how they've gone about it and how you can take advantage of their experience and knowledge and some of the lessons that they have learned. So, for those not familiar with NAWHC, the National Association for Workplace Healthcare, formerly National Association for Worksite Health Centers, is focused on helping employers and providers, consultants, clinic vendors, and others who are involved in direct contracting for medical care at the worksite, particularly through on-site, near-site, mobile, and virtual health centers. We work with both the purchaser side and the supplier and provider side to help them expand their capabilities and to be able to offer multiple types of services. This is one of our educational programs. We have 2 sessions a month plus an annual conference. We also do national benchmarking services, purchasing support, networking opportunities, and support. Again, we have a nation's largest clearinghouse of information for those involved with what we call employer managed healthcare. So please visit our website, join our LinkedIn group, and get more information about this and upcoming programs. What we're going to have coming up next week, we have a roundtable on what to measure to gauge the performance of a worksite clinic. Then later on in February, we have another webinar on Beyond the Launch, how to drive ongoing engagement with employer-sponsored health centers. At the end of February, we'll be in Austin, Texas for the 2026 Workplace Health Center Summit. And then now its own annual forum, Employer Managed Healthcare Worksite Clinic and Direct Contracting Strategies, will be April 8th and 9th in downtown St. Louis. So we'll hope you'll be able to join us for these. All the webinars are recorded, and we will be sending out links to individuals who attended, and we'll also make it available to our entire membership. So please, if you're interested in being part of NAWHC, please go to the website and get more information about that. Today, I'm pleased to have Sid Bhatt, Founder and Chief Executive Officer for SigmaMD, and Dr. Doug Schram, Chief Medical Officer of Improved Health Clinics, to provide our content. So with that, let me turn it over to Sid. Sid, good morning.
Thank you, Larry. Honored to be here, everyone. I'm Sid Bhatt. I'm the founder and CEO of SigmaMD. SigmaMD is built from the ground up for direct care, on-site, near-site clinics. We're very proud of what we've accomplished. We have an amazing team of clinical advisors, engineers, product people, and what we do really well is interact with our customers, our users, and engage them in the product development roadmap. So hopefully today we can talk a little bit more about how we work with one of our very dear customers, Improved Health Clinics. And Doug is very much involved with defining and shaping our product roadmap and getting to minor details that are very important for the employees, the clinicians at IHC, and getting these things prioritized and getting these things built so that the workflows are improved. And so we'll talk about some examples today of things that we have implemented, we have seen drive value to the users. And it's going to be an interactive discussion today. If you have any questions, feel free to put them in the chat. I'll let Doug introduce himself.
Thanks, Sid. Yes, I'm Doug Schram. I'm the Chief Medical Officer of Improved Health Clinics. We're a worksite clinic company who has 11 sites of care across 7 states. Our primary or our only client actually is Alliance Coal Company, underground coal mining company. We have 8 mining sites, 1 engineering site, and 2 administrative sites where we have on-site clinics. Alliance Cola has around 11,500 covered lives in their health plan. They are a self-funded, self-administered insurance plan with no stop loss. And so they see having on-site work clinics as crucial to their mission to provide the best care possible to all of their employees and their families. And so we see that as IHC as, we're part of that team. So we got into this and said, you might want to start. I think we met at a meeting, and I took the reins at IHC about a little over a year ago, and looked at our existing EMR and realized that it was not up to the task for what I envisioned for the company and for all of the clinics. It was very bulky software. It was not implemented well. We had just a lot of issues, to be honest, across each site, not a lot of standardization. And when there was employee turnover, there wasn't a really good system in place for training. And so, a lot of the data was in disarray, and I didn't really feel that I could get a handle on what was going on across the enterprise. And so I embarked on the very distasteful process of looking for a new electronic medical record system. I've done this several times before in my career at various places, and it's never fun. Those of you who've gone through it know how disruptive it is. But we decided really that this is what we needed to do to be able to start gathering our data and really to use that change, the pain of that change, as an opportunity to reevaluate all of our workflows, and to really see what's working, what's not, and to use it as an opportunity to standardize as many things as we could across the operations. So we embarked on that, and that whole journey, I had several things I was looking for. I wanted to get as many things, if you will, as many applications into one application as possible. I really didn't want one vendor for telehealth, another vendor for my EMR, another vendor for potential reporting or a portal or other things. And so I was looking for someone who could do it all, and I was a little bit skeptical. I ran into Sid at a meeting, and we started talking, and his software for us fit the bill. In particular, there's just a low barrier for training, ease of use. One of the things that we really ran into a problem with our previous vendor was, like most EMR softwares, it was designed for billing third-party Medicare and such. And the way that we're set up, it's really more of a DPC concierge type practice. We don't bill third parties. We have a contract with our primary client. So, the software is a lot lighter. It doesn't have all those complex billing components to it. And it really, in many ways, for us, fit the bill. So that's how we kind of got started. And I got very excited because I've got a background in kind of EMR design and a few things. And I found that Sid was very open. Sigma was very open to working with us to figure out different ways to support our workflows and ideas for software development, growth, and that sort of thing. So it's been great. Of course, like anything, some rocky times, here and there, little things popping up, but it's been very, very good. So,
Thank you, Doug. Let's go to the next slide, please. Okay, so today that was a fantastic introduction, Doug, and what we're going to do is talk a little bit about some of the challenges you had, and why those challenges crop up. You mentioned the EMR systems being optimized, the traditional systems being optimized for billing, third-party billing. We can cover things that are unique today in the on-site clinic workflows, why they're different than a traditional primary care or family medicine clinic, and what type of flows. We can even talk about examples of certain flows that are different and things you need in the EMR system. We can talk about measurement outcomes a bit, what sort of reporting goes along with that to pass up to the ultimate client, which is the employer group, and ultimately talk about technology and what you see are some key outcomes from technology that we can build for you, things, tools, reporting, APIs. Where do you see the clinic being a year from now, 2 years from now, in terms of optimization? So this will be the agenda for today. I'll pass it to you, Doug, to add to this if you'd like.
Yeah, thanks, Sid. I think, that first bullet point, worksite clinics is not traditional primary care. I think, as you kind of pointed out, and I mentioned earlier that, traditional primary care clinic is focused on billing third party, and we're not. And the expectations for our performance are a little bit different in a lot of ways, I think, than a traditional primary care clinic. We work closely with an employer on site. They have higher expectations for availability, I think, for rapidity of response, to issues, that sort of thing. I mean, they're looking at it as something to enhance presenteeism, to use it as a recruiting and retention tool, that sort of thing. So we have to be on our game, so to speak. And I think an EMR that supports that is really, really helpful. And, a patient portal, for example, the ability to securely text patients. We have guys who are on night shift, so if they need refills, things like that, they can send in a request at 2 a.m., while they're thinking about it. This is clearly very different than a traditional primary care practice. We don't do call, but we can sort of do a form of call, if you will, through the patient portal. And you're exactly right that employers do expect measurable value, and that's a moving target. And I'd love to talk with others about what you use for your KPIs and measurement and kind of proving the financial value. But we get very often from our client that there's a lot of intangibles here. They just love having somebody there and involved and available for their folks, and especially because these are rural areas and many of these people don't have access to healthcare. So those are a lot of intangibles, but yeah, we're also working on all the other financial measures as well. So yeah, that's technology is a huge component of supporting what we're trying to do, especially in these rural areas.
Thank you, Doug. Let's go to the next slide, Larry. Doug, let's set technology aside for a second and just talk about how a worksite clinic operates. I recognize the audience is primarily worksite clinic folks, clinicians, but it would help, generally speaking, differences, and we can kind of talk about specific workflows. For example, scheduling. How does patient scheduling work? Communication. How does patient communication work? That might differ from the traditional primary care model. Charting, lab ordering, e-prescribing. Maybe pick a few other points that you think are important to talk about.
Well, I think, from a workflow perspective, a lot of them are, in our environment are similar to, primary care. I mean, you have folks who need refills, and we need a way to respond to that, to send in the refills. Having e-prescribing capability is huge because those refills can come to me directly instead of going through my nurse and you have another person involved. It's more efficient from that perspective. Scheduling, this system allows us to schedule people right there. As a provider, I can schedule someone right there while I'm sitting with them before they walk out of the room. So they don't have to go by somebody, front desk, person, and have that interaction and how, when does he want you back? Oh, 3 weeks. I thought I meant 3 months, whatever. I can do it right there. And it cuts down on miscommunications. So yeah, there are a few, maybe some slight differences, but in how we might operate from a primary care clinic, but using these technologies, I think really lets us just be more efficient with fewer staff. And as you pointed out here on this slide, lean staffing models, each of our sites generally are with one provider, nurse practitioners at all sites except for two. Actually, one administrative physician, myself, who floats around, and then we have one other physician at one site who assists, and then we have nurse practitioners at all other sites. And each generally has one staff, MA, LPN, or RN. So, it's lean, but it works because we use the technology to support it.
What do patients expect, Doug, in terms of access and expectations, and how do they evaluate whether they would go to the on-site clinic or go down to the primary care center that they're familiar with that's not on-site?
Yeah, that's a great question because our health plan, it's really quite unique. The Alliance Cole Health Plan, it's not our health plan, but it is those of our patients. The Alliance Cole Health Plan has no premium and no deductible, no out-of-pocket, nothing. Their health care is free if they go to where they have direct contracts. So their care is free at our on-site clinic, but it's also free at many places locally for them. And so that means that we have to provide services and things that are above and beyond what they might get out there in the wild, so to speak, because it doesn't cost them anything no matter where they go. Right. So um, that's one big difference, where we're trying to work on that. But we do have convenience as a big ally, bringing people in, and because we're right there on site, it's a huge boon for the employer to have us right there and available. Um,
Doug, do you feel that technology can influence how preventative care is managed? For example, using AI to identify gaps in care, or creating stratification risk scores so that your team and the medical directors there can focus on the patients that need 80% of the focus. Um, how can that sort of technology drive better outcomes and ultimately, make the employer feel like they're seeing a lot of value?
Yeah, my vision for how to use AI in this environment would be to um, really leverage it to pick up the biggest risk for medicine in general, and that is errors of omission. It's not errors of commission. It's not, that you did something wrong necessarily. It's that you forgot to do something. And I think AI has huge potential in looking across a population, looking across charts and picking up things that were not picked up. You meant to follow up on, a patient's elevated hemoglobin A1C or elevated blood pressure, or just you missed it in that visit. You just didn't see it. You were focused on something else. If you can have, an AI system behind you saying, hey, by the way, did you see this? Did you notice that? Is there something you want to do about that? I think that would be huge. And it is the Pareto principle, really. It's, 20% of your patients are really creating 80% of your clinical activity. I think there's a huge amount of potential here. In fact, we were looking into this, I was talking to another company about doing, a private instance of ChatGPT and trying to get it trained up on medical model and using our EMR data just to kind of go back and say, okay, here's what's going on. And then I ran into you and we had these discussions about building in, AI into the back end. So, yeah, I think this is the direction it's going. It's the direction it needs to go. There's too many data points out there right now for us to keep track of. I've been in medicine for 35, I don't know, nearly 40 years, whatever. And it's like a fire hose now. It's an exponential curve of things that we have to keep track of. And I don't really see a way we can do it efficiently without something like AI.
Great. Let's move to the next slide, please. Okay. Doug, kind of staying on the subject of AI, the good news is technology is moving rapidly. There are a lot of changes since we started working together to now. I I think it's better models. I think if you were to simplify, cost is going down on the AI front, better accessibility, so more robust, more advanced models. We're talking about large language models here, are more easily accessible. Those barriers are going away. So kind of think about mainframe computers to what you have on the palm of your hands. It's 100 times more powerful than a mainframe computer. That's the rate at which AI is moving, and glad to let you know and the audience know that um, things that you might consider very advanced, such as pulling in citations, real-time detection of omission from the clinical notes. As long as the AI is listening in an ambient way to the visit recording, it can, in real time, flag issues and suggest a course of action, a course of treatment. Um, so there are many advances beyond the AI scribe, which is traditionally how clinicians think about, say the word AI, but what does that mean? Oh, okay, you have a listener that essentially jots the note for you and saves you 15 minutes of having to write the note manually. Sure, you might use templates and speed that up, but you still have to spend time doing it. Now AI is able to generate very precise and accurate notes, and SigmaMD has that built in. Uh, but we're not stopping there. And I think we can spend a few minutes talking about what the next evolution will look like. So we have tools like Open Evidence where they have access to literature, open source literature like PubMed, to closed wall type, firewall type literature where you need access and licensing, JAMA, for example, New England Journal of Medicine. But context doesn't stop with the uh, literature. You have guidelines as well. Let's not forget that. You also have literature. Language models rely on content, right? So they learn from content. So you have, kind of count with one hand the type of content they need access to. You have, like I said, open source literature, journals, closed off journals, license that require licensing. Then you have your guidelines. Then you have your calculators. The calculators are formulas at the end of the day, but they do feed into large language models. And the fifth is the medication guidelines, right? So your patient handouts. So with those five things, you have companies like Open Evidence who are essentially able to process that data through their custom large language models. So they do have their own learning models to then build a chatbot and an AI listener that listens to the visit to do all these amazing things that we talked about. But there's a big gap there, which is the patient chart, right? And so, Doug, question for you is, when you think about context for an AI model, where do you see the value of the patient chart above and beyond the literature that the models learn from?
Well, I see the literature as, when you're either going in to see the patient or you've completed a patient visit and you're processing what just happened and am I missing anything and what else do we need to do? Um, but there's all that information in between, as you were kind of alluding to, that during a patient encounter, you're gathering symptoms, you're gathering, a variety of I think potentially important information. This is, I think, kind of the big gap. We need something that looks at what is actually happening. What was that blood pressure? And what is that relative to their previous blood pressures? What is their weight relative to their previous weights? These are things that Open Evidence is not going to be able to tackle, though I know they do have their own kind of quote patient record. They have a BAA you can sign. It's fantastic, actually. You can put some information in there, but it's not really designed to longitudinally track a patient and all, things that are specific to that patient. Not population health, but really specific to that particular patient. I think this is where AI built into your EMR is key. Before we went with Sigma, we were using Freed for AI note documentation. And it's a fantastic product. I'd recommend anyone to use Freed. It's great. There are a lot of them out there, a lot of others available. Um, but for us in our implementation, the downside to Freed was that we had to take the note, it was created in another system, cut and paste, if you will, whether it was from a browser or whatever, and then put it into the system. And you also had to tell Freed, this is a 58-year-old female with et cetera and so forth. The advantage of having built an AI is that it already knows this is a 58-year-old female whose name is Jane, and uses the appropriate pronouns, does all the things that are, when you configure your notes, it takes a big lift off of just note generation, and it's much more accurate. There's some interesting things that are talking about. I think Epic has a huge database, and I can't remember exactly what it's called. And they're touting their gigantic database and they're running AI off of it, but they're finding problems with something called semantic drift. They're recognizing that a lot of the information that they're pulling out of these electronic medical record systems are erroneous because clinicians are using templates. And templates were a fantastic innovation back in the 90s. I got very excited about that. I thought, oh, great, I don't have to write all this out by hand anymore or dictate it into Dragon Dictate or whatever. So just use a template. Well, the problem is when you use a template, you're in a hurry. You use your, say, for example, normal physical exam template. It says the tympanic membranes, your ears, they're intact, this, and this. Well, you may not have even performed that exam, but the template just pulls it across and your eyes skimmed over it, you forgot to update it. And so it goes into the record that this patient has an intact tympanic membranes. Well, they may not have intact tympanic membranes, and somewhere down the line, somebody else may notice that, and then you don't know when that actually happened. You've introduced error into the record. And what Epic has been training their AI on is, a lot of misinformation. It's not intentional, but it's just the way that we document as clinicians. So having something that's listening in real time and knows that you did listen to their lungs, or you did look at their tympanic membranes, or you did not, I think is huge. So I would trust that data much more, not only in an individual context, a single patient longitudinally, but also now you've got more accurate records in your individual, so your population health metrics should be more accurate. So
That's a great segue, Doug, into the content of this slide. So for the audience, it would be very helpful to understand the difference between cloud native versus legacy server-based EMRs. I think one of the things that I think is very important to talk about, which is not on the slide, is cost, ongoing cost, implementation cost. That's very important. But then there are things that impact speed, whether it's product development speed, releasing new features as it relates to requests from the clinic. Hey, I need this. This is very useful. And then all your other customers say the same thing. This sort of idea of voting based, building things based on how many folks need it, to things like training existing staff, the ramp up for new staff joining. You want them to get ramped up quickly. And ultimately what your patients are expecting, right? We can't forget the patients. They are a customer indirectly for the EMR. So could you talk a little bit about, you have tons of experience with the legacy systems as well. Can you please highlight some of the differences?
Yeah, for us, of course, cost was extremely important, which immediately ruled out Epic. Even as yeah, piggybacking potentially onto some universities, we had some opportunities there, and honestly, it took some time to even find out how that would work out. But for us, something like Epic was like, using a shotgun to kill a gnat. A lot of kind of a heavy hitter system. But in looking at other electronic medical record systems that were really more along the lines of what we were looking at, it was very important. Cost was extremely important, and the way that we were, for example, in our legacy system, we're being billed by encounter, and that was problematic because some of our folks were, the definition of an encounter in our organization at the time we started this journey was not clear across the entire enterprise. And so some people would say, oh, well, I did this for this patient. That's an encounter. And they would, put it into the system. It may not have actually been a face-to-face encounter, but then we would get billed for that. So we're being billed for a lot of things that honestly weren't actual encounters because that system was for practices that do billing, right? They bill third party. So I think they kind of saw that as well. Okay, we're just taking a chunk out of your revenues, out of your billing revenues, and that's what you're basically using to pay your EMR with. Since we weren't doing that, it didn't make a lot of sense for us. So that was one really big thing. The other was the reliability of our old vendor. A week didn't go by where somebody from one of our sites was saying they could not access the EMR. That's huge. Anybody who's used one knows that's your, it's your tool. It's your primary tool to do business. And when that's down, everything's down. And we're also looking at, okay, do we try to teach or retrain everyone on our old EMR and try to get everything straightened out? Well, as burdensome as that system was, it just really did not seem to be an option. So when I ran into Sid and found Sigma, really it was sort of I was like, well, can I check it out? Sid was like, yeah, I'll give you access to it. I go, what do you mean? Like, yeah, just play with it. Here's a test site. Have fun. And so I just started teaching myself over a weekend, and I went, oh, okay, this is actually really, really easy. I can teach myself this thing myself simply. Of course, with support, these guys are always available. And I just kind of picked that up and then kind of implemented it out, and everyone's just really picked it up. We've done some of our own internal training, best practices, that sort of thing, but it was extremely easy. We did a full-blown implementation in, say, less than 3 months across all 11 sites. So we had no downtime. The system's been extremely stable. Those are all just things that were big criteria for me. And for us, especially being across so many different sites, we really needed everybody to be up all the time.
Thank you, Doug. It would help, I think, the audience talk about migrations. That's always scary for clinics. We're talking about patient records and other data elements, faxes, attachments to the patient chart. How do you move that? Is it a manual process? Is it automated? Does your new EMR take care of it? What sort of criteria were you evaluating when you were making a decision to change your EMR?
Well, we needed to get as much information out of the old one as possible, obviously, and electronically transmitted would be the ultimate. Unfortunately, the way that we had configured the previous EMR, in my view, it wasn't configured in an optimum way. Notes were not stored or saved in an appropriate way for transfer through a CCDA file, for example. And so we did chart prints, in many cases to cover the scanned documents and other like radiology reports, other things that came in PDF files. We just basically took the entire chart, scanned it, uploaded it as a PDF file into Sigma. And then you guys, prior to that, when each patient was created, we exported CCDA files out of our old vendor, and then you guys imported those. So yeah, it was a lift, but I've been through several of these, and I've been through far worse. So to say an EMR transition is not painful would be a lie. There's a lot there, a lot to it, but we had processes for dealing with duplicates and for other issues, and takes a little time to smooth a few things out, but it went really, really well.
Thank you, Doug. Let's go to the next slide, Larry. Okay, now let's talk about APIs. That's a word that may or may not make sense to clinicians that are non-technical. Doug, what are APIs and why are APIs important? And why are cloud native EMRs in a better position to support APIs?
Well, application programmer interfaces, APIs, those I think, what I like about Sigma is that it's a web native application. When you look back at many applications like Cerner we had in the hospital, for example, is one, and I'd say most probably large EMRs, even small to medium-sized EMRs today, are not web native, meaning they're not built natively using cloud architecture, up in the web. They're server-based. They may have a web interface to them, but they're still server-based and distributed servers and that sort of thing. In that sense, some still require download onto your laptop, whatever, as a stationary sitting application. And this, with any web-based application like this or web native, you can access it through any device that has a browser. So I can be my cell phone, I can use the Sigma app, or I actually can just log into the Sigma application, if you will, through a browser. I can get it on an iPad, I can get it anywhere on any computer at any time. And as long as I'm not downloading PHI, obviously, or anything onto that particular device, I'm in good shape. So, if I forget my laptop, I'm at home, I need to look up something real quick. Boom, it's there. It's an easy login. It also seems to be much more stable than some of these other systems that are really built on older technology, and they just keep getting layers of code added to them. They seem to become more unstable the more functionality and features that are added. From my understanding, Sid, and talking with you and how you guys have built this, it really is connecting different services, if you will, right? Like, different services connected through APIs, and it makes it much more flexible, much faster, and much leaner. Pulling up a patient is very quick. Doing most tasks in Sigma is very quick. And I think that's just really the underlying architecture, independent of you being Sigma. I think just this type of web native architecture is really where things need to go. And it's great. I will be sitting there working, and all of a sudden, a little box will pop up and say, "Hey, you have an update for Sigma is available," and you just click refresh, and your screen refreshes, and if there's a bug that was reported earlier, it's suddenly fixed. New functionality appears. It really is pretty remarkable. So yeah, I think that it's like the difference between turning the Queen Mary and turning a tugboat. This kind of application development seems like it's quite rapid, allows for a lot of quick development, design, bug fixes, that sort of thing, and it's constant rapid development. And so it's evolving kind of it's evolving in the direction that we're going. And that I like. I like seeing progress, and I'm like, oh, well, this is going to come out in the second quarter of 2027. You're like, okay, how long can I wait for that? And we've got all these issues, these things that need to be solved now. And I think this form of web development, not specific to Sigma, I think it's just this form that you guys have chosen to develop is really the wave of the future. I think it's the way to go.
Thanks, Doug. Now, in terms of how EMR systems should operate, listening and observing, showing up to on-site clinics, shadowing patients, taking input from not just the physician that's treating the patient or the clinician that's treating the patient, but talking to front office or back office. What do you think is the ideal way of product development that would ultimately lead to better product design quickly rather than going through phases of implementation and not really getting it right, and then you kind of make iterations and then still not hitting the mark. You have dealt with many EMR systems in the past. What have you seen as best practices?
Well, I think what we've tried to do as an organization is to we use a system called Coda that we um, have everyone have access to, where they can report any bugs or ideas or pain points. And then we rank those, we look at those, and then share those with you guys, and you'll take a look. And it allows everyone to be on literally on the same page on a CODA document. Everyone's just kind of looking at, okay, what do you guys see as important? I try to go through those, cull those out to rank them in order of importance, knowing you guys aren't going to fix everything next week. It'd be great if you could, if you give us all the functionality we're asking for next week. Um, but I think that allows us to stay focused on what's important, and then allows you guys to not have to drink from a fire hose. And then you can also um, categorize what's most important, not only for us as one of your clients. We know you have many clients, and so you guys have to fold that into your development roadmap. So, on our end, on our side, we just keep a list. And I think that's the easiest way to handle it. It's similar to what other EMR companies have, they may have, conferences, things like that, or meetings, webinars and stuff where people all kind of get together and talk about pain points, and its groups may rank functionality and features. But I like this because it really allows me to focus on my organization. And I throw that over to you, and then you put that in the context of other organizations. Okay, so I don't have to really stop and think about another organization and go, oh, okay, well, that's great. That might work for you, but that doesn't work for me. I spend the time only going, okay, this is what I need to work for me. And I may not always get exactly what I want or need at the moment. It may be well, you could do it this way, or maybe we need to change our workflow just slightly to adjust to how the software is developing, knowing that there are others who are also contributing to its development. So I don't know, again, kind of a long-winded answer to maybe a short question, but that's how we've approached it. And I feel like going forward, best way to communicate to you guys what we need.
Thanks, Doug. Yeah, I just want to use an example, perhaps. Yes, you did share your quota list of uh, ranked feature requests and workflow changes, and we took that, we ranked it, we compared it to the needs of other clinics. Um, an example would be prior authorization, building a prior authorization workflow as part of the lab and imaging ordering workflow, right? So essentially holding the order until the prior authorization was approved, and then automating the transmission of the order once the prior authorization had come in. So it sounds simple on the surface, but there's a lot of nuances that have to be worked through, like having the prior authorization entity as a contact in the contacts directory, and then essentially tying it to the patient, holding the order until the prior authorization was sent out, comes back, approved or denied. Right? You also have that workflow to go through, but we really enjoy product development from a observation and engagement side of things, where we are big fans of like just getting into the clinic and seeing things and hearing things, and then mapping it out on the whiteboard and then building it. So we tend to pride ourselves, the entire company, in engaging with physicians and taking input and letting them shape our product roadmap. Let's go to the next slide, Larry. All right. So I think we're getting towards the last set of slides here. So just keeping track of time here. One of the things that we should probably talk about is measurement. So that goes with things like reporting utilization. Um, you have reports around what type of appointments, are they coded to certain CPT and ICD codes. While we're not dealing with insurance exactly, and one might ask the question, well, why are you talking about codes? Ultimately, coding can help with categorization and better insights. So Doug, please talk about reports. What do you consider a good utilization report?
Yeah, for us, it's number of belly buttons, so to speak. So we kind of put it that are seen in any given site, say in a month or a quarter or a year. Some belly buttons may need to be seen, more than once in any given measurement time period, right? So we'll look at total number of visits, the categorization of those visits, like what were they for, and we've broken it down into different appointment types, is what's in Sigma. But we defined our own appointment types. So say a 20-minute follow-up visit, for example, or a urgent visit or pre-employment physical, for example. So I can measure those things, give those to the employer going, hey, over at this site, you did 3 pre-employment physicals, you saw, 4 work injury issues, you saw, these sort of things. So it's very helpful. They ask for that sort of data every month. They want to know who's being seen and generally for what. But a 20-minute follow-up visit, for example, doesn't tell you what they were being seen for. Was it follow-up for hypertension? Was it diabetes? Was it both? We don't know. So that doesn't give you a lot of insight into population health or any of that. You can look at the patient's problem list if you want to know if Mr. Jones obviously has diabetes or hypertension. But going back to my client, can I tell them we're seeing this much diabetes in the clinic, we're seeing this much hypertension, and that's where other things come along, and things that you and I have talked about, Sid, that where in the schedule and as we're checking people out, so to speak, as we move a visit from booked to completed, having that clinical information, what was this specific visit for, tied to that. So it's sort of like, being doing a super bill or billing, but it's not. It's much easier, much faster, much cleaner, and allows the same kind of reporting that you would get out of a traditional system that has these super bills, and you have to put all these, ICD-10 codes in and all your CPTs and everything. So, yeah, those things are all extremely important, things that my client wants to see. And it, I don't think they always act on that information. They're generally not in a position to act on that information, as the employer. But it shows them that we're paying attention. And if we come up with initiatives, for example, create a metabolic clinic, where we're going to see people and get very aggressive with metabolic syndrome, with all the things that go along with that, diabetes, hypertension, hyperlipidemia, we can start, really seeing the results of our efforts through that. We work with an epidemiologist, but there's only so much that he can do if he has no data, right? So this is key, and I know you guys understand all that, and we're getting right now great data that's helping us show our value to the employer. Like, here's what's going on. If, for example, we know that at one site we have, say, 300 employees, but we're seeing very few people coming through the clinics. Well, the question is why? That just prompts more questions. Is there an issue with the provider? Is it that these are just healthy people who don't like going to the doctor, or they may not know about the on-site clinics, or so that prompts us as management to be able to go in and say, okay, what's happening here? Well, we're not focused on productivity. To us, a visit isn't a dollar. Okay, a visit is taking care of somebody, and so we want to know, if we're not taking care of as many people as we think we should be at one site, why is that happening, and what can we do to turn that around? So those are the kind of ways that we, on a very high level, use data. It's extremely important.
Yeah, Doug, I feel like we could have a whole webinar on this topic of reporting.
Oh, yeah.
Spans so many different dimensions, from utilization to clinical reports to productivity reports. There's so much to talk about. And then there's the AI side of things. How does AI influence report automation and actually actioning insights and actions based on reports? So maybe that's a topic we'll talk to Larry about for our next webinar. And there's so much we can do there. We talked about AI-powered documentation, so scribing. We talked about that earlier. I think we're pretty good with this slide. Why don't we go to the next slide, Larry? Yeah, so let me just try and summarize this, and then Doug can kind of add to what I'm saying. So I think in conclusion, we talked about a lot of things today, um, and ultimately the goal here is better patient outcomes. We also don't want to forget about the health of the clinician, their mental health, their well-being, right? And technology can influence all of the above. And picking the right technology obviously means evaluation. You want to make sure you play around with it like Doug did. Ask for a trial, play around with it for about a week, and see how the workflows match up with your expectations. Is the workflow that you're seeing in the new system meeting the needs of your clinic, of your employees, and not just the providers, but also your front office and your back office? How long is it going to take the implementation? What about data migration? Will the new system take care of migrating the data for you from the old system? Is there any cost to the migration? We don't charge anything for migrating data, but that's something you want to evaluate. Can the new system accept CCDA file formats? That's the standard data format for migrating medical records from one system to the other. Also, try and evaluate the product development methodology of the company you choose to work with. How do they decide what's a priority, and how quickly are they implementing new features? And also bug fixes. How quickly do those bug fixes come out? What is your cadence of product development and new feature releases? And talk to some of their current customers to kind of validate what you're hearing. And at the end of the day, just how aligned is, I think this is crucial. How aligned is your new system with your vision? You have a certain vision as a clinic, as a clinician, of what it means to provide good healthcare, and talk to the company and see if they're aligned with your values and how you perceive outcomes and good patient care. Doug, do you want to add anything to that?
Yeah, the only thing I'd like to add is don't underestimate the impact that this has on your staff. A good EMR versus a bad one. Even a bad one, you can get used to it. And a lot of times people don't even really realize how much pain they're in. They just get used to the pain and the inefficiencies and the workarounds. So, things like having even built-in AI note capability. If you've never, it's a lot of fun to show that to a clinician for the first time. They're like almost like an ape who's seen fire for the first time. Like, oh my God, this is crazy. It is like a dream come true for a lot of people, and they're skeptical. Many of the clinicians are skeptical that this isn't really going to work that well. That they've seen a lot of things over the years with a lot of promise. But well done note-taking capability, AI note-taking capability is truly amazing. So I would just say, in to your point about workflows and that sort of thing, absolutely make sure that scheduling is what you need, that your staff can use all of those things. Security, all those things are extremely important. Yeah, don't underestimate the impact on your staff. For our folks, it's really reduced a lot of cognitive burden and hopefully burnout. So that's one of the goals.
Thank you, Doug. Well, we're at the end here. If anyone needs to get a hold of either of us, our contact information is up on the slide. Welcome anyone to reach out, ask questions. We're here to network and connect. Larry, should we go to Q&A?
Sure. So we have still a few people left, but let me ask Ernie Clevenger. Been a while since we've been able to talk. Why don't you give us an idea of any questions you have or any experiences you'd like to share with us?
I think the presentation has been excellent. Thank you very much. I'm excited to hear about the integration of AI with the electronic medical record. I think that is absolutely the best way to go, not only as a prompt for the physician, but admittedly, soon the AI will bypass the physician's knowledge. And the physician will use their knowledge and their patient preference along with the AI in order to determine the best treatment pattern for the patient. Larry, thank you for asking.
Thank you. Any comments, Doug or Sid?
Yeah, if I could make a comment about that, I find it really interesting. We're at, the early days of AI, in 20 years, if hopefully I'm alive that long, but it'll be kind of interesting to look back at these early days. And right now there's a lot of pushback. And Ernie, you're exactly right. Having this inside of your EMR is key. Um, but there's a lot of pushback from a lot of people that, oh, AI is not, it's not accurate. And, you need to be careful. And especially with ChatGPT, which is trained on lots of sources, including all kinds of websites of questionable validity. But my argument is, okay, I understand that even ChatGPT can be wrong and it hallucinates, it makes up things. Correct. But how many, how many times have I been wrong? As a physician, as a human being, AI runs circles around me. I can't possibly know all of this. The data required to be a physician anymore, the amount of knowledge, it's off the charts. And so to have a system available where I can look at it and say, hey, um, you know, what what's the dosage of amlodipine, for example, to use a commonly used antihypertensive drug? And if AI comes back and says, well, it's 10,000 milligrams every 5 hours, I'm going to say, well, no, that's clearly wrong. No, I'm not paying attention to that. So AI doesn't obviate the need for the physician. It augments the physician. It's like bionics to a physician. It's like makes you that much faster and better if you just use your head. You don't allow AI to take over. So that's my
Doug, thank you. Doug, thank you for saying that. You remind me of a comment, a quote by Dr. John Eisenberg, who is the chair of the NIH several years ago. And his comment was, physicians are correct 70% of the time. And that's a
No.
startling comment because we patients think that you know everything at
right,
all points in time.
right.
And you're human like us, and knowledge is moving quickly.
Exactly. And right now, I think there's some shame among providers that they have to use it. They're like, oh, it's like I have to Google it. Well, my patients are Googling it. That means I don't know something. And the most dangerous provider is the one that does not realize that they don't know something. It's,
Yeah.
so, or they're not sure of something. And even sometimes when I'm sure, I'm 95% sure if this was my mother, if this was my brother, and I'm only 95% sure, let me just look this up real quick. Let me get on open evidence. Just type a couple sentences in. And and then, yes, it confirms what I thought. Okay, we're good. But many times it's been like, oh, wow, that guideline just got updated last year, and that hasn't been transmitted well across the medical community.
Yeah,
Medical textbooks are
another
years behind.
closing comment, Larry, if you'll permit. Um, there was a book written called Megatrends by John Nasbitt, probably 25 years ago, and he predicted that as technology grows, so must touch. High tech requires high touch. And no human is going to be motivated by AI like another human. And so you may find AI bypasses your capability, much like radiologists are seeing today. The
Right.
AI can interpret film, MRIs, et cetera, often better than the radiologists. We're seeing those studies in JAMA and the New England Journal of Medicine. But to inform the patient and to motivate the patient to take the appropriate action, it still needs touch. It needs a human.
I
Yeah.
agree
Thanks.
100%.
Thanks for your comments, Ernie. Two quick questions before we close out. One was relating to alerts. A lot of EMRs over the years created a variety of alerts for the provider, and we've heard complaints that providers, I'm getting too many alerts. I'm just going to ignore them. Is that what AI does as well, or is there a way to temper that, or is it a different approach?
Yeah, I just as a clinician, I'll tell you, it's a real thing. They termed it years ago called alert fatigue,
Great.
where you literally just go through and you just go click, 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 and you
Hmm.
actually, especially with drug interactions,
Hmm.
those are the most annoying. It reacts with grapefruit juice. Okay, great, or food. Things that clinically are not relevant. AI, I think, will strip away a lot of that. Um, one thing I do like about what Sigma is doing, and I hope other EMRs jump on board with this, is doing external alerts. Many require you to log into something to say, hey, you've got a critical lab value. You have to log into your EMR and look at your pain to see what's going on. Sigma allows external notifications that, hey, something's going on. Hey, you need to look at this. And if I'm off in another task and not right at my EMR, I can get alerted about things that matter, and I can configure those alerts. So, yeah, I don't know, Sid, if you have anything to add to that from an engineering perspective.
Yeah, I think AI can learn. So an alert for patient X might not be so relevant, but the same alert for patient Y is actually important. And the great thing about having AI in the EMR, and I can't stress this enough, is context. You have access to the patient chart. You know enough about the patient. And systems that are external to the EMR, that are touting their AI, will always have that as a disadvantage. They don't know anything about the patient, right? And so you saw Scribe take off with companies offering a Scribe tool, but then there's inefficiencies. You have to copy and paste. It sits external to the patient record. Long term, what I see is AI is going to be foundationally a core layer within the EMR system, and leverage not just articles that exist in the World Wide Web, but also the patient. So important.
Great. Thank
Well,
you. And
Sid,
the last question we have relates to security. You talked about a lot of concerns about outside groups coming in or individuals holding data ransom or blocking the system from working. In a cloud system, I mean, again, it is in the cloud. Can someone more easily get into it or less as easily than a regular EMR?
Well, with cloud systems, there's actually better security because you have a known set of protocols that you need to. Essentially, it's a checklist, right? It's called penetration testing. You go through a pen test with a certified vendor, and they go through a battery of tests to look at not just technical implementation, but operational implementation within the company, within the customer premise. And they then look at access to ports. Are certain ports open that shouldn't be? How is two-factor authentication implemented? So I would say that cloud systems have evolved significantly over the last decade, where there are processes and procedures in place. And if you kind of run through the HIPAA privacy and security rules, which is part of pen tests, right? So there are companies offering penetration testing, as well as compliance to HIPAA. So as long as your EMR system has the check mark for both of those, it's equivalent to having servers on site.
Great. Thanks very much. I'm sorry, we're out of time now. I want to again thank Dr. Doug Schram and Sid Bhatt for participating and giving us the time and expertise. A copy of this recording, or a link, I should say, will be sent out to all those who registered, and will be available to all NAWIC members on our website, and we will be promoting it through our newsletter. So thank you, everyone, for staying. Stay warm, and we hope to see you at the next NAWIC program. Take care, everyone.
Thank you,
Bye-bye.
Larry. Bye-bye.